So it's 2 o'clock now, so we will be starting. So hello everyone, and welcome to this webinar with Tracy Afifi. My name is Sarah Forte. I'm the Knowledge Transfer Coordinator for the Canadian Research Data Center Network. Before I introduce our speaker for today, I would like to take a couple of minutes to present the network for those of you who may not be familiar with, who may not be familiar with the network. So as you can see, please, next slide, Tracy. As you can see on the map shown on this slide, the CRDCN is truly a pan-Canadian network comprising 27 research data centers across the country. These centers are secure computer labs, generally located on a university campus. They allow researchers with an approved project to use the wealth of data gathered by Statistics Canada, including household and longitudinal surveys, census data, and an increasing number of administrative data sets. Last year, more than 1,500 researchers from various disciplines have accessed an RDC, and about a third of them were graduate students. The research carried through the network is very diverse and have helped to better understand social and economic developments affecting the whole society, as well as a factor affecting individual life course and well-being. This includes population aging and demographic changes, economic integration of immigrant, socio-economic determinants of health, income inequality, labor market participation, and child development, among other topics. Some of this research will be featured at our annual conference coming up at the end of this month on October 31 and November 1 in Saskatoon. Early bird fees are still available if you would like to join us, and you're most welcome to do so. To know more about us, I invite you to visit our website. You can see the address right there, where, among other things, you can search the online bibliography to find the most recent publications in your area of interest. And you can also browse the data search engine which we have developed to see what data sets are available through the network for your own research purposes. So without further ado, let me introduce our speaker for today. Next slide, please. Thank you. So Tracy is an associate professor in the Department of Community Health Sciences at the University of Manitoba, and she holds the CRDCN New Investigator Award. She has 2 primary research interests, child maltreatment, of course, and this includes child abuse, neglect, physical punishment, and exposure to intimate partner violence, but she is also interested in problem gambling. She has published extensively on these 2 topics, and her presentation today actually is based on a few of her recent publications. Now, before we start, just a bit of housekeeping. Tracy will speak for about 50 minutes, and then we will have a Q&A session. Note that all microphones will be automatically muted during her presentation. To ask a question, you can either write it using the question tab on the right-hand side of the webinar platform. Click and you can write it, and I will read it for you. Or you can raise your hand. You click the button with the little hand, and I will unmute your mic, and the time comes for you to ask it out loud yourself to Tracy. So Tracy, thank you very much for being with us today and for accepting to do this webinar, and the mic is now over to you.
Well, thank you very much. Thanks for the invitation. I'm happy to be here with you, sort of, over the internet to talk about some of the research that we've done. So today I will be talking about child maltreatment in Canada, a fact sheet. And before we begin, I just wanted to make a few acknowledgements, both for funding and data access. So the funding sources from the projects that I'm going to be presenting today come from mainly the Canadian Institutes of Health Research and Research Manitoba. And all the data comes from Statistics Canada that I'll be presenting from the Canadian Community Health Survey. And all the work has been done at the Manitoba Research Data Center with Dr. Ian Clara being very helpful in vetting all these projects for us. So I just wanted to make those acknowledgements. And also acknowledgements to my co-authors and collaborators who have worked with me on these projects. So they're all listed there from different institutions, including many people with me at the University of Manitoba, McMaster University, and also the Public Health Agency of Canada. So I'll be talking for less than an hour so that we can have time for questions at the end. So please feel free to ask those questions once we're done. So an overview of what I'll talk about in the next little while. This webinar will further understanding of child abuse in Canada, and it'll have three main areas of data that I'll be talking about. So the first one will be talking about the recent estimates of prevalence of child abuse in Canada, and I'll also talk about the co-occurrence of different types of child abuse as well, so the prevalence of having more than one type of child abuse. We'll also be discussing what factors are associated with the likelihood of contact with child protection organizations among those who have reported a history of child abuse. And we'll also look at the relationships between several types of child abuse and mental and physical health conditions. And all of these data come from Canada using our nationally representative data, which I'll talk about. So before I talk about the data, I think it's important just to define our terms so we know what we're talking about when we say the terms child maltreatment. So generally, what's included in child maltreatment would be physical abuse, sexual abuse, emotional abuse, exposure to intimate partner violence, or IPV, physical neglect, emotional neglect, and physical punishment. Now, of course, there's other things that can be included in this list, such as exploitation of children, but generally these types of abuse and neglect are the most commonly found around when we use the term child maltreatment. But I also use the term child abuse, and I just wanted to clarify when I use the word child abuse and when I use the word child maltreatment. So generally speaking, when I use child abuse, I'm referring to these forms of abuse, which is physical, sexual, and emotional abuse, and exposure to IPV, and with the absence of neglect. So a little bit of background information before we start with some of the data from our studies. When we think about Canada and our state of knowledge of our understanding about how child abuse occurs in Canada, we're actually, compared to the other parts of the world, the number of child maltreatment studies that have been conducted in Canada are far fewer. And prior to 2012, the data used to study child maltreatment was less diverse. So before 2012, we didn't have any nationally representative data on child maltreatment from the general population in Canada. And although we did have a lot of really high quality studies, the data sets came from reported cases of child maltreatment. So this would be data that the CIS data from PHAC, for example, but also other reported cases of child maltreatment in terms of justice data that people have collected from different provinces. Also community samples, hospital data, clinical samples, school-based samples, and also we had some provincial surveys from Ontario. The Ontario Child Health Survey had indicators of child maltreatment in the early 90s and in their second data collection as well. So we had some very good sources of data, but compared to other countries, it was not as diverse. And of course, as mentioned, we never had that nationally representative data in Canada. So why do we need Canadian data? Well, without this representative data, we don't really have an accurate understanding of child maltreatment within the Canadian context. So we don't have simple things like prevalence, and we also don't have our understanding of the details in which abuse occurs within Canada is limited if we actually don't have representative data to study its occurrence. So why is this important? Well, we want to be able to make clinical and policy decisions with information and with evidence. And so without representative and high quality data in Canada, we're either making those clinical and policy decisions without information or evidence, or perhaps with only partial understanding. Alternatively, we can also generalize data from other countries to the Canadian context and use evidence from other places to help guide those clinical and policy decisions, and that may or may not be okay. So it's hard to know when data can actually be generalized from one country to another. But in the absence of no data, perhaps that's sometimes not a bad alternative. So then in 2012, we had the Canadian Community Health Survey, the CCHS 2012, which I'll refer to in the rest of the slides. So this study was important for many reasons, but one reason was because it was the first nationally representative cross-sectional survey that had a focus on mental health that actually included measures of child abuse. So a little bit about the data, for those of you who don't know, I'm sure many of you are familiar with it, but the data were collected basically over a one-year period starting early in 2012 for the duration of the year. And the response rate was quite good at almost 80% for household and 70% for person response rate. And the sample included the 10 provinces with a sample size of just over 25,000 individuals of people aged 15 years and older. So again, why was this study important? Because we know there's been many CCHS surveys been conducted, but this one was important for me for the reason that it was the first nationally representative survey in Canada to include these measures of child abuse. So this meant that for the first time, we were able to actually estimate the prevalence of child abuse in Canada. And so they asked the child abuse questions, but not to everyone in the studies in the CCHS. So they included the child abuse questions for only those respondents who were 18 years and older. So the sample size was a little bit lower, just under 24,000 people of ages 18 and older. So the data I'll be presenting today will be for this portion of the sample. So again, what is child maltreatment? So it's the same slide that I showed you earlier. So these are the types of child maltreatment that we usually include. And the CCHS included physical abuse, exposure to intimate partner violence, and sexual abuse. So some of the measures, 3 types of abuse, but notably not all types of child maltreatment were included. Now for the CCHS survey, the physical abuse and exposure to intimate partner violence questions came from the Childhood Experiences of Violence questionnaire. And the sexual abuse questions were based on items that were used in previous community and nationally representative surveys. So I'm just going to talk a little bit about how child abuse was defined in these data sets and how we coded them. So for the physical abuse and exposure to intimate partner violence that came from the CEVQ, we followed the guidelines from that tool and how they recommended that we code the data. So it was followed according to those recommendations. So physical abuse, there's actually 3 questions that tapped into physical abuse. So the first question was asked before the age of 16, how many times did an adult slap you on the face, head, or ears, or hit or spank you with something hard to hurt you? And the respondent was able to answer on an ordinal scale from never all the way up to more than 10 times. So according to the coding of the tool, the respondents that responded never or 1 to 2 times would be coded as no, and people that responded 3 times or greater would be coded as yes for this item. The second physical abuse item was asked how many times did an adult push, grab, shove, or throw something at you to hurt you? And again, the same response categories were available and the same coding pattern was implemented. So never or 1 to 2 times was no, and 3 times or more was coded as yes. And the third physical abuse item was more severe. How many times did an adult kick, bite, punch, choke, burn you, or physically attack you in some way? So again, the same coding, but because this item was more severe, only the people that answered never were coded as no, and anyone who reported this 1 time or more were coded as yes. So the physical abuse items were 3 individual items, and in some of the research that we conduct, we do look at the individual items, and sometimes we look at child abuse or physical abuse as 1 item together. So when we're looking at any physical abuse, what we're actually looking at is yes to 1 or more of the 3 physical abuse items that I just indicated. For sexual abuse, there were 2 questions that were asked. So before the age of 16, how many times did an adult force you or attempt to force you into any unwanted sexual activity by threatening you or holding you down or hurting you in some way? And the response categories were the same as for physical abuse. But anyone reporting this 1 time or more was coded as yes, and only the people responding never were coded as no. And the sexual abuse item, how many times did an adult touch you against your will in any sexual way? By this I mean anything from unwanted touching or grabbing to kissing or fondling. And the same response categories and the same coding as never equals no. So for sexual abuse, we use both items, and if a respondent said yes to either one or both of these, then they would be indicated that yes for experiencing any sexual abuse. And what item was used to measure exposure to intimate partner violence, or IPV? And the question asked, how many times did you see or hear anyone of your parents, step-parents, or guardians hit each other or another adult in your home? And the same response categories, and as indicated by the tool, we coded never and 1 or 2 times as no, and 3 times or greater as yes. So that's the coding of our child abuse items in the CCHS, and so we use these items to ask the first question, which was, what is the prevalence of child abuse in Canada? So the data from this study were published in June of 2014 in the Canadian Medical Association Journal in a study called Child Abuse and Mental Disorders in Canada. So what we found was 32% of the adult population in Canada has experienced child abuse, and that included physical abuse, sexual abuse, and or exposure to intimate partner violence. Now there are a lot of data in this paper, but this number, 32%, was the number in the paper that got the most attention. So the easiest number to compute, but it shows that it's really important for us to have this data in Canada as it did receive a lot of attention, the simple prevalence. If we look at the individual types of child abuse in Canada, we can break it down and we can see that 26% reported physical abuse, 10% reported sexual abuse, and about 8% reported experiences exposure to intimate partner violence. So these are not mutually exclusive categories. And we also wanted to look at gender differences between the prevalence of the types of abuse, and what we found that women were more likely than men to experience sexual abuse, so about 14% to approximately 6%. Women were more likely than men to experience exposure to IPV, so it's about 9% to 7%. And men were more likely than women to have experienced physical abuse, so about 31% to 21%. And these numbers for the differences among sex are similar to other countries. So what is the prevalence of experiencing more than one type of child abuse in Canada? So what we know is that child abuse often doesn't occur as one type of child abuse, but when someone experiences abuse, they may be more likely to also experience more than one type of child abuse. So it was important to look at how respondents were reporting having experienced more than one type of abuse. So this data were published in an article in 2015, published in Child Abuse and Neglect. So these are mutually exclusive categories that you see. So these are multiple experiences of child abuse in Canada. One of the limitations to note that these are types of abuse that people reported, but we don't know whether or not they reported them concurrently or if one and then the other. So we don't know the timing of these events, but we know that during their life, during their childhood, they experienced these types, multiple experiences of child abuse. So the first category here is the whole sample, and then by men and women. So we can see that 68% reported no child abuse. Physical abuse only was reported at about 17%, and that is by far the highest percent. So most people, if they're experiencing one type of abuse, it was physical abuse alone. 4% reported sexual abuse alone, 1.4% experienced exposure to IPV alone. Physical and sexual abuse was reported at about 3%, just under 4% for physical abuse and exposure to IPV. Sexual abuse with exposure to IPV was only 0.4%, and experiencing all three types was about 2.4% in the sample. And you can see here the categories of the breakdown for men and women. So physical abuse occurred alone rather than with, it was more likely to occur alone rather than with other types of child abuse, so about 17% to 9%. IPV, exposure to IPV actually was less likely to occur alone than it was with other types of abuse. So if we think of how exposure to intimate partner violence might occur, that might make sense. And then similar portions of respondents experienced sexual abuse alone, as well as sexual abuse with other types. So about 4% experienced sexual abuse alone, and about 6% reported sexual abuse along with other types of child abuse. So what is the relationship between child abuse and contact with child protection organizations in Canada? So the item in the CCHS 2012 asked about contact with child protection organizations. So they asked this with the child abuse module. And they asked, before the age of 16, did you ever see or talk to anyone from a child protection organization about difficulties at home? And the individual was able to respond yes or no to that variable. So we were interested in those who were responding yes. Now, notably, this item is limited in the sense that the individual would have to remember this occurring in their childhood, number one, and also they would have to have the understanding that the person that they were talking to was from a child protection organization. So that's also something to consider with as a limitation of this. Also, it's difficulties at home. So we know that individuals can come to just talk to families from child protection agencies about difficulties that are not child abuse. So this item wasn't specific to that, but it does give us some insight into the people's experience with abuse and contact with child protection organizations. So we found that about 8%, or just under 7.6% of the adult population with a history of child abuse in Canada reported having had contact with child protection organizations. So of the people that reported a child abuse history in the data, only 7.6% of them indicated that they had contact with child protection organizations. So when we wanted to look at factors that were related to either an increased or decreased likelihood of contact, we found that women compared to men, and being never married or separated and divorced compared to being married, were each associated with an increased likelihood of contact with child protection organizations, and this is among only those people that were reporting a child abuse history. And we found that older age, higher education, higher household income, and country of birth other than Canada were each associated with decreased odds of contact with child protection organizations among those who were reporting a child abuse history. And then we wanted to look at how the child abuse experience was related to contact. So were there certain types of child abuse experiences that were associated with a greater likelihood of contact with child protection organizations? So we found that for people with any physical abuse, about 8% had reported contact with an organization, about 10% for sexual abuse, about 17% for any exposure to IPV, and among anyone with a child abuse history, as we said, 7.6% had contact with child protection agencies. Now, when we looked at the odds ratios, experiencing any physical abuse increased your likelihood of contact by 4.4 times, so that's an odds ratio of 4.4. Sexual abuse was 3.6, and any exposure to IPV was 6.8 increased odds, and 4.6 for any child abuse. So having these experiences, of course, did increase the odds of contact with child protection organizations. And when we go back now to look at the mutually exclusive groups, which we reported the prevalence of just previously, we can see the percent of contact for child protection organizations along with the odds of that child abuse experience being related to increased likelihood of contact with child protection organizations. So you can see that when we look at it this way, we have 1.8% of people without child abuse reported contact with child protection organizations, about 4% for physical abuse, about 4% for sexual abuse only, 8% for exposure to IPV only, 8% for physical and sexual abuse, 15% for physical and exposure to IPV, about 11% for sexual abuse and exposure to IPV, and the highest percent, almost 25% of people having contact with IPV if they experienced all three types of child abuse. So this probably makes sense. The more types of abuse one experiences, perhaps the worse the situation for that individual and the increased likelihood that that individual would be in contact with child protection organizations. And you can see the corresponding odds ratios here. So the lowest odds ratio is actually for physical abuse only, and climbing up higher for almost 10 times for physical abuse if it's with exposure to IPV, and then the highest, 16 increased odds for experiencing all three types of abuse. And we can also look at this in terms of not just what individual types of abuse were experienced, but also the number of abuse, child abuse experiences. So no abuse, one type only, two types, or three types. And you can see that it increases the percent, the more types of abuse, regardless of the type. So the more types you're experiencing, it increases the prevalence of contact with child protection organizations, and the odds ratios increase from about 3 to about 8 to about 16. So you can see a trend of a dose-response relationship. So the more types of abuse you experience increases the odds that you will be in contact with child protection organization in a stepwise manner. So some interesting things to point out about those findings. Physical abuse alone had the highest prevalence in the study. So you'll remember that physical abuse only was about 16.8%. However, it was associated with one of the lowest odds of contact with child protection organizations. So why is this important, and what does this mean? So what we were thinking is that because it has one of the highest prevalence associated with the lowest odds, it might be that additional strategies for increasing reporting might be necessary, and it may also be necessary to also be creating awareness of the acts that constitute physical abuse towards children. So we know that spanking is allowed in Canada under the criminal code, and so there is, sometimes it's hard for people to understand what is okay and what is not okay according to the law, and therefore that would have an impact on reporting. Also, increased awareness of effective non-physical discipline alternatives for parents may also be necessary to shift the societal norms and to further reduce our reliance on physical discipline, which has the potential to escalate into abusive acts. So individuals who are spanked or other physical forces used for discipline, those individuals are more likely to have experience physical abuse. So perhaps if we can reduce the physical discipline and use more non-physical discipline alternatives, this may have an impact on our percent of physical abuse. And when we think about the findings for sexual abuse, when sexual abuse occurred in combination with other types of child abuse, the likelihood of contact with child protection increased. So that's an important finding. So it's harder to detect sexual abuse, I think, when it's occurring on its own. In addition, sexual abuse is often surrounded by secrecy or accompanied by threats to the child not to tell anyone. This coupled with the fact that it's typically no physical findings, although not always, with sexual abuse, or perhaps not as visible as it would be with marks left from physical abuse. it may make it harder to and more difficult to detect. So increasing our ability to identify all child abuse experiences is important for protecting our children from harm. Not only sexual abuse, but also physical abuse would benefit from strategies to enhance its detection, and perhaps would then correspond with an increased likelihood of child protection contact for those who are experiencing abuse. And notably, some of these cases, especially for reports of child abuse, may be reported directly to the police, so that's something to consider as well. So the findings also show a dose-response relationship with increasing number of types corresponding to increasing odds of contact. And this is an indication that more severe cases of child abuse might be more likely to be reported or become known to authorities. And we know that is generally the case, that reported cases of child abuse are known to be the tip of the iceberg, with many more people experiencing child abuse that don't get reported, and often it's those cases that are the most severe that are reported to child protection organizations. Okay, so moving on to relationships between child abuse and health outcomes in Canada. So we'll start with the relationship between child abuse and adult mental health conditions. So the data for this study were published in the same CMAJ article previously mentioned that came out in 2014. So we'll talk a little bit about how mental disorders and mental conditions were assessed and how we used them in this study. So there were several mental disorders that were assessed based on lifetime time frame, and they were assessed using the CD diagnosis and the CD-DSM-4 criteria. And those disorders included depression, bipolar disorder, generalized anxiety disorder, alcohol abuse or dependence, and drug abuse or dependence. So in addition to these lifetime disorders, there are also self-reported mental health conditions that were included in the data. So these were not based on CD criteria, but rather were just asked of the respondent whether or not they had these conditions. So they were asked if a long-term health condition diagnosed by a health professional lasted or expected to last 6 months or more. And these included obsessive compulsive disorder, panic disorder, PTSD, phobias, attention deficit disorder, eating disorders, and learning disabilities. So the individual indicated whether or not they had these using self-report. So because of the difference between how these were assessed, we actually kept these separate. So we looked at the mental disorders based on the CD diagnosis as one category, and then the self-reported mental health conditions as another category. And the survey also asked about suicidal ideation and attempts. And so they asked if a respondent ever seriously thought about committing suicide or taking his or her own life, yes or no. And also for suicide attempts, they asked if the respondent had ever attempted suicide or tried to take his or her own life, yes or no. So for the findings, I'll just sort of summarize the general findings in this slide, and then I'll go and I'll show you some of the details of what we found. But generally speaking, when adjusting for socio-demographic variables, all types of child abuse were associated with increased odds of all mental conditions that we looked at. So those are our AOR1 models that we reported in the study. When we further adjusted for other child abuse types and mental disorders, most of the CD diagnosis and several of the self-reported mental conditions remained associated with physical abuse and sexual abuse. And there was a general trend of increasing number of child abuse experiences corresponding with the greater odds of mental conditions. So again, we found this dose-response relationship with individuals who experience more types of child abuse having increased odds for poorer outcomes. So here are the data for the mental health conditions. So these are the disorders that were diagnosed using the CD criteria. And I will orient you to the slide. So these are AOR ones. So these are our adjusted odds ratios that were adjusted for age, sex, visible minority status, Canadian-born status, education, income, marital status, and province. So what we find here is with the blue bar is our reference group with no child abuse, and the green bar is our any child abuse category. So you can go to the paper if you're interested. We did look at all the individual items here. So we looked at the individual items of for physical abuse, all three individuals, including any physical abuse. We looked at the sexual abuse items and the exposure to intimate partner violence items, and then we looked at any abuse. The table is quite dense with odds ratios and different models, and so for simplicity of presenting it here, I'm only going to be presenting the any child abuse category, but if you're interested in looking at the results specific to physical abuse, sexual abuse, or exposure to IPV, those are available in the table, in the CMAJ publication. So these are, again, for any child abuse. So we have our reference category here, and we have our depression category here. So we have an odds of 2.9. Now these are all, as I mentioned, statistically significant. So experiencing any type of child abuse significantly increased the odds of having depression by almost 3 times. For bipolar disorder, child abuse increased the likelihood of having bipolar disorder by 3.6 times. Child abuse increased the likelihood of experiencing GAD by 2.7 times. And child abuse increased the likelihood that the individual would have alcohol abuse or dependence by 2.5 times. And any child abuse increased the likelihood of drug abuse or dependence by 3.4 times. So all of these findings were statistically significant and independent of sociodemographic variables. Now, these are the results for the self-reported mental health conditions. So these are current conditions, and these are not based on CD diagnosis. But all of these findings were also statistically significant in our AOR1 models. So these models are adjusted for the same covariates that were mentioned in the previous slide. And what we found was any child abuse increased the likelihood of OCD by 3 times. Increase the likelihood of panic disorder by an odds of 2.2, increase the likelihood of reporting PTSD by an odds of 4.4. It increased the likelihood of having phobias by 3.2 times, increased the likelihood of ADD by 2.2 times, and increased the likelihood of eating disorders by 4.7 times, and a learning disability by 1.7 times. So you can see all of these odds ratios are quite moderate in size and all statistically significant. And these are the findings for having experienced any child abuse with suicidal ideation and suicide attempts. So you can see that any experience of child abuse increased the likelihood of reporting suicidal ideation by 4.1 times. And if you experienced child abuse, you were 6.1 times more likely to indicate that you had attempted suicide in your lifetime. So these are quite significant effects. We also wanted to look at severity in terms of number of child abuse types that were experienced. So we looked at that same variable: no child abuse, 1 type of abuse, 2 types of abuse, or 3 types. So the no child abuse is the blue, 1 type is the green, 2 types is the turquoise, and 3 types is the darker blue. And we looked at this adjusted for the same sociodemographic variables as previously mentioned, and we looked at it, we've reported it here for the broad categories of outcomes. And again, if you're interested in the individual categories, those are also included in the CMAJ paper. But what you'll note from all of these is that stepwise increase for each outcome. So you can see that for experiencing 1, 2, or 3 types, the more types of abuse that an individual experienced increased in a stepwise direction the odds that they would report any mental disorder. So the more types of abuse experienced, the greater likelihood you're going to also have report a mental disorder. So the odds of up to increased odds of 8 times for those who experience 3 types. If we go over here, that was this any mental disorder is the CD diagnosed. Over here is the self-reported mental disorders, same increased effect, just a little bit lower at about 7 odds. And we have very elevated odds for suicidal ideation and attempts. So you can see that reporting 1, 2, or 3 types of child abuse significantly increased the odds in a stepwise direction for suicidal ideation. So if you experience three types of child abuse, your odds of reporting suicidal ideation were increased by about almost 14 times. And if you reported 3 types of child abuse, your odds of reporting a suicide attempt was elevated by almost, by just over 27 times increased odds. And so we also looked at, do sex differences exist in the associations between child abuse and adult mental conditions in Canada? So we did look at interaction effects, and we found that we did find some significant sex-related effects, but they were only noted for ADD and exposure to intimate partner violence and any child abuse, with the effects being greater for women. And we found that sex-related effects were also found for several child abuse types and suicidal ideation attempts, with a higher prevalence noted for women in all cases. So there were some gender effects noted. So our conclusions from the data just reported, we can confirm, of course, that child abuse is an important public health problem globally, but it's also an important public health concern here in Canada. It's important that all healthcare providers are aware of the relationship between child abuse and certain mental disorders. And it's important that they understand that when a child is being treated for a mental disorder, that they may have had an experience of child abuse. And success in preventing child abuse could lead to a reduction in the prevalence of mental disorders. So now we'll change our focus to what is the relationship between child abuse experiences and adult physical health conditions in adulthood in Canada. So we know that a lot of data, if you're familiar with the child maltreatment literature, there's been a lot of data, of course, over the past several decades on the relationship between child abuse and mental disorders. So the previous data that I reported is really important because it comes, it's from nationally representative data within Canada. However, we do know from previous data that those relationships existed. But there is actually a much smaller literature on the relationship between child abuse and physical health. So compared to what we know about mental health, we don't know as much about physical health. And also, there's almost a resistance in some areas, and that there could be a link between child abuse and physical health outcomes. So the understanding how the mechanisms of that relationship are not as clear for some individuals. So how does child abuse actually have an impact on physical health? And so I will talk a little bit about that, because I think it's important to think about how that, the mechanisms in which that relationship can occur. So the data on child abuse and physical health conditions in adulthood were published somewhat recently, March 2016, in Health Reports, in a publication called Child Abuse and Physical Health in Adulthood. So how was physical health assessed in the CCHS 2012? Well, there were 13 self-reported physical health conditions, so similar to how some of the mental health conditions were reported previously in the previous study that we talked about. So again, it was thought to be a current measure. So it was a lifetime mental health conditions diagnosed by a health professional lasted or expected to last 6 months or more. And the physical health conditions included asthma, arthritis, back problems, high blood pressure, migraine headaches, chronic bronchitis, emphysema, and COPD, and that category was limited to those who were ages 35 plus. Diabetes, epilepsy, heart disease, cancer, stroke, bowel disease, which included Crohn's, irritable bowel syndrome, and bowel incontinence, and also colitis, and chronic fatigue syndrome. So just to summarize what we found, and then again I will show some of the more individual data from that study. We found that all types of child abuse were associated with an increased likelihood of having a physical health condition, so just looking at any physical health conditions of those that were previously listed. And we also looked at all types of child abuse and its relationships to obesity in adulthood. And we found that a significant relationship was found for all three types of child abuse. So child abuse increased the likelihood of obesity in adulthood by 1.2 times. For sexual abuse, the odds ratio was 1.4 times increased odds. And for exposure of intimate partner violence, increased the odds of obesity in adulthood by 1.3 times. So here's a summary of the findings for this study. We found that when we looked at any child abuse was associated with an increased likelihood of these 9 physical health conditions out of the 13 that are listed here. And we found that these relationships were significant after adjusting for socio-demographic variables, smoking, and obesity. So more of the details of this study can be found if you actually go to the Health Reports study that's available. So child abuse and any physical health condition, here are the more detailed slides. So I'll orient you to the slide here again. These were unadjusted odds ratios, and we're looking here, we're presenting the individual types of child abuse and how that was related to an increased likelihood of having any physical health condition. So just looking at the any category here. So these were all found to be significantly, statistically significant. So any child abuse was associated with a 1.5 times increased odds of having a physical health condition. Any physical abuse with 1.4 times increased odds. Being slapped, hit, or spanked was associated with a 1.4 times increased odds, and that was significant. Being pushed, grabbed, or shoved was associated with a 1.7 times increased odds of having a physical health condition. Being kicked, bit, or punched was associated with a 1.8 times increased odds. Experiencing sexual abuse increased your odds by 2 times of having a physical health condition. And exposure to IPV increased the likelihood of a physical health condition by 1.6 times. Now these are the individual physical health conditions. So now we're looking at the category of any child abuse and the individual physical health conditions. So the ones with the asterisks above them are the ones that were statistically significant. So not all of them in this slide were significant. But arthritis, back problems, high blood pressure, migraine, and chronic bronchitis were all statistically significant. So having experienced any child abuse increased the likelihood that you would experience those physical health conditions. Now these odds ratios are also adjusted for all the socio-demographic variables previously mentioned and also adjusted for smoking and obesity. The results were still statistically significant. And if we look at the next slide for the other health conditions, again, we have just the ones with the asterisks above them are the ones that were statistically significant. So any child abuse increased the odds of, cancer, stroke, bowel disease, chronic fatigue syndrome, and of course, any physical health condition as previously mentioned. So odds ratios ranging on this slide from about 1.3 times for cancer to 2.6 times for chronic fatigue syndrome. Now, this slide's a little bit busy, but again, we wanted to show the the stepwise trend, so the increasing number of types corresponding to the increased odds, stepwise increased odds of experiencing outcomes. The asterisks above the cluster are the ones that were shown that the stepwise increases were statistically significant. And you see the pattern, generally speaking. Here's the pattern here from increased odds from 1.2 to 1.7 to 2.2 for arthritis. These numbers here were not statistically different, but these numbers were. And here you can see a more steeper stepwise increase. Here, these numbers were not statistically different, nor were these, but the odds ratio of 2 were different than 3. So not a complete stepwise trend in all cases, but the trend is definitely there, with more types being worse. You can see that for cancer, you can see it for stroke, bowel disease, chronic fatigue syndrome, and any physical health condition. So again, you are noting that trend in dose response, with having experienced more types of child abuse corresponding with the increased likelihood of experiencing these individual physical health conditions. So that's the general trend for most conditions. We also looked at sex differences in these relationships, and what we found was sex differences were noted for back problems, chronic bronchitis, emphysema, COPD, cancer, and chronic fatigue syndrome. And in all cases, the effects were slightly stronger for women than for men. So the mechanisms, I think it's really important to talk about the mechanisms so that we can really have a more complete understanding of how this relationship works, and also to understand the criticism of this area. So there are several explanations for how the relationship between child abuse and physical health conditions can occur. Of course, we can't confirm these with cross-sectional data that we've used here, but there's a lot of work in this area. I've cited many of the studies here. And for the full citation of this work, you can go to the health reports references and get the full access to this discussion, and also to the references in this area. So how is this possible? Well, infants who experience abuse have been known to have a higher hormonal reactivity to stress, so that can definitely have an impact on our physical health conditions. There's links between child abuse and physical health that may also reflect physiological responses to violence. So exposure to abuse may affect the hypothalamus pituitary adrenaline axis, leading to excessive secretion of cortisol, and that leads to physiological responses such as an increased heart rate and blood pressure. And over time, having increased heart rate and blood pressure can undoubtedly have an impact on your physical health. There's also research in the area of neuroimaging and neurochemical and proton spectroscopy data has indicated that individuals exposed to abuse and violence have acute, subacute, and chronic changes in the brain. So they can actually see changes in the structure of your brain when looking at the neuroimaging, so of course this can have an impact on our physical health conditions. Also, children who are abused often report alterations in their sleeping patterns, which can worsen physical symptoms. Child abuse neglect is also associated with alterations in immune system and inflammation, so that has been noted in previous research, and of course those situations can have an impact on physical health conditions. And there may also be other indirect pathways between child abuse and physical health conditions. So that may be through mental health conditions. So child abuse may increase the likelihood of mental conditions, and the mental health conditions can then increase the likelihood of physical health conditions. And also individuals exposed to child maltreatment may also have emotional, cognitive, or behavioral responses to the adversity, and that may include substance abuse, overeating, for example, and those things would definitely can have an impact on health problems. So healthcare providers may have a limited awareness of the role between child abuse in relation to physical health conditions. So it's important that this is a known relationship and association. And from a public health perspective, it's increasingly recognized that prevention of child abuse may have major implications for reducing mental health problems, but it's also possible that reducing child abuse may lead to better physical health outcomes as well. So it's a very important target for prevention. So to wrap it up, the limitations of the studies. I've reported on 4 studies, I believe, here today, and many of them have very similar limitations because, of course, the data used in those studies are all the same. So limitations of our data are that they're cross-sectional and retrospective in nature, which means that we can't make claims about the causal relationships between child abuse and the outcomes mentioned here. The data were all self-reported. So, of course, with some mental conditions, we used CD diagnoses, but all of the items were self-reported with regard to other conditions and experiences of child abuse. The assessment of child abuse in the CCHS for sexual abuse may not be adequate enough to capture all sexual abuse experiences that would be considered harmful or considered illegal. Measures of emotional maltreatment and neglect were not included. So if we had those measures, we would have a more complete understanding of child maltreatment from the Canadian context. And several child and family characteristics were not available in the data, such as family poverty, parental substance abuse, parental mental health problems, for example. So these variables would be quite informative for furthering our understanding in this area. So a summary of the important findings reported today: 32% of the adult population in Canada has experienced child abuse. 7.6% of the adults with a child abuse history have reported contact with child protection organizations. Child abuse has robust associations with all mental health conditions, including suicidal ideation and attempts. Experiencing abuse in childhood was associated with increased odds of having 9 out of the 13 physical health conditions in adulthood. And from a public health standpoint, these findings highlight the urgent need to make prevention of child abuse a priority in Canada. Moving forward, we need to continue to invest in nationally representative data on child maltreatment in Canada. We need to add measures of neglect and emotional maltreatment to surveys in Canada. We need to also assess child and family characteristics such as poverty, parental substance use, and mental health problems, as previously mentioned. And we also need to assess child abuse along with other indicators of health, education, justice, and gender identity. So thank you very much. I will put up the references and be happy to answer any questions or have a discussion if people are interested.
Yes. Wow, thank you, Tracy. This was a very thorough presentation. And to me, you provided the disturbing results. Of course, I'm not an expert in the field at all, but as mentioned, at the beginning of your presentation, this is like this survey allowed to have a real sense of the prevalence in Canada for the first time. So I guess there's a lot of material here for questions. Maybe I can start by one, and just about this prevalence. You mentioned 32%. And you said that the CCHS is kind of first time that we have a real sense of the prevalence. How does that number compare to what we knew previously? Of course, we had not much survey before, so this number came as a surprise. And how does it compare in the rest of, compared to other countries, for instance?
Yes, okay, so that's an excellent question. So we were anticipating the number was going to be around what it was, so around a third or 32%. And the reason for that is we do have measures of child abuse within Canada from survey data from Ontario, for example. So that gives us an indicator. Of course, we can't generalize that to the country. So the Ontario Child Health Survey had older, from the 90s, measures of some types of child abuse. And also there are many nationally representative studies in the United States that have looked at child abuse for many years now. And so our numbers are actually pretty similar to what you would see from the United States. So we were expecting the number, but of course it is high. It's 1 in 3, and many people, especially those who are not knowledgeable about the field of child maltreatment, were quite surprised by that. Those people who are in the field of child maltreatment, often I got the response of, well, you didn't include neglect and you didn't include emotional maltreatment, so that number is probably actually higher.
Mm-hmm. Thank you. Okay, so I guess I've started to receive questions, and here is one. Let's open it, by Nicolas Corneau-Tremblay, and he asked, when you talk about education, is it parents' education or the education of abused child once adult? I think this question is related to the portion where you discuss contact with child protection organization, where you mentioned that higher education, I think,
yes,
decrease the likelihood.
Yes, so in that study, looking at education, it was the education of the respondent. So if the respondent had higher education, they were less likely to have reported contact with child protection organizations. And it'd be really interesting to know education of the parent, not just educational level, but there's also other aspects of education. That's, I think, an area of child maltreatment that we could do more work in, but those measures were not available in the data.
Okay, thank you. And here's another one, is by Anne Scott. Was indigenous population included?
Yeah, so we actually didn't look at specifically the indigenous populations in this data set. We know that the data were only of the 10 provinces, so it wouldn't have been representative of indigenous people across Canada, and so we didn't look at it individually or specifically. So I can't really speak to anything specific to indigenous communities.
Thank you. Here's another one by Alan Picallo. Will you be sharing the next slide? Yes, we will be. The next slide will be available after the presentation, Alan. Okay. So next one here is, sorry, I have to move up. Questions are coming up and it's moving down, I think. All right. Thank you for noting the limitation of the study, as emotional abuse and abuse by neglect are usually, co-occurring with all other forms of abuse. They are the most common form of abuse in my work in Alberta and the Yukon.
Mm-hmm. Yeah, it's of course, emotional maltreatment probably occurs with all other types of abuse, especially. And then we know from data from the United States, also from reported cases of child abuse in Canada from the CIS data from the Public Health Agency of Canada, we know that neglect is a very prevalent type of child maltreatment as well. So it is a definite limitation of the CCHS, and it would be great to be able to have indicators of those included in the future.
Thank you. And Jana McDonald, who asked the previous, made the previous comments, go on saying, exposure to adult substance abuse is an area of grave concern. The definition of witnessing IPV that is used in the CCHS asks about witnesses violence by a parent guardian against another adult in the home, not necessarily against a parent's intimate partner. This is an issue that comes up in my own analysis of the data. Question: how did you accommodate this in your work?
Well, there's only one item of intimate partner violence, which we called exposure to IPV in the home. And now it's true that it could have been adults fighting and not necessarily intimate partner violence. But we called it that because it was likely at least one parent within the home that was involved with that. So it is a limitation of how the question is worded. That being said, violence within the home, whether it's between two parents or a parent and another adult, is quite traumatic for a child, quite stressful, and the implications of living and being exposed to that is probably very similar.
Thank you. Here's another one by Jana McDonald. StatCan has been reporting on child abuse and maltreatment for over a decade. Is this not a recognized source of stats and research?
I'm not sure what data that she may be referring to, but from a nationally representative perspective, these are the first data that from the CCHS 2012 that have been available and that have been published and reported in Canada. So
okay, maybe I can unmute Jana's mic to see whether maybe she wants to be more specific. Jana, your mic is now open. You can speak if you wish. Hello? She's not. Okay, so I guess we'll go on. Here's François Thériault. Is the 32% prevalence estimate representative of current rates of abuse in today's children?
Yes.
He goes on saying, could the estimate be inflated by higher rates of child abuse in older generations? Have you looked at age-stratified prevalence estimates?
Yes, so it's a really good question. So we can't say that right now 32% of children today in Canada are experiencing child abuse, and that's why we're very careful in our wording. We say that 32% of adults in Canada have reported experiences of child abuse, because that's precisely what it is. So whether or not it's 32% now, currently we don't know. We are interested in looking at cohort effects, and we're currently doing that with people at the Public Health Agency of Canada. And we've also looked at cohort effects in American data as well.
Thank you. I don't see any. Please, if you have a question, if you'd like to ask a question to Tracy, raise your hand. Maybe I can ask one again, Tracy, about child protection organization. I don't know if I missed it during your presentation. What are these organizations? What do you mean by child? Is this governmental agencies, or could it be church related or things like that?
Yes, so it would also be open to the interpretation of the person who was reading that, but generally this would be it's slightly different depending on what province you're in, but this would be places like Child Protective Services, Children's Aid, any agency where you would be reporting child abuse to. So Child Protective Services, those sorts of things. So depending on the jurisdiction, it might be a different organization, but the function would be similar to any kind of mandatory reporting of child abuse neglect.
All right, thank you. So it's 10 after 3 now. Is there any other question? Let me look in case someone wrote while you were answering that one. Yes, I have another one from Katrina Joubert. You said all types of child abuse were associated with increased odds of obesity in adulthood. What is the measure you use for, I guess, measuring obesity?
Obesity. So we had measures of height and weight, and we used those measures to compute BMI. And then we use the obesity range of BMI to determine to measure that indicator.
Thank you. Marta Berziska, I'm sorry for pronouncing the name. You noted for some of the physical abuse types, responses of 1 or 2 times were coded as no abuse. What was the logic here?
Well, so that's the tool that's used, the Canadian Experience of Violence questionnaire. That's how they recommend that. That's the coding algorithm for the tool. So we followed how to code the variables based on the psychometrics of the tool that was implemented. So that's one reason why we did it. But the other reason is because we only did that for things that were of less severity. So we wanted to make sure that we had we were not just capturing someone who may have been slapped on the face one time by an adult, but we were trying to really capture those people who experienced physical abuse more than once or on an ongoing basis. And that's typical in a lot of different data where they're trying to look at individuals who have experienced child abuse more chronically, and not the situation where it's a less severe type of physical force that may have been done once, and then the parent was, upset that they did that, and then decided, okay, that will never happen again, and didn't do it. So for the less severe types of physical force, we used that coding as indicated by the tool that was used. But for the more severe types of abuse, physical abuse, and also for sexual abuse, it was if it happened one time, it was severe, and therefore that's definitely physical abuse.
Thank you. And here's another one from CRDCN. How does the prevalence of child abuse compare across the 10 provinces?
So that is actually in the CMAJ paper. So you can refer to the CMAJ paper to get those details. And so I will recall from my mind, and I'm hoping that I'm getting it right. I think that there were many provinces that there were no statistical differences for, and I believe the highest prevalence of abuse was found in Manitoba, and I believe Saskatchewan, and I believe there were some in places that had a lower prevalence along the East Coast. But you'd have to refer to that paper for those details. I'm sorry, I can't recall them exactly. But we did look at that in the CMAJ paper.
All right, thank you. Here's another question from Amy Ornstein. Is the next iteration of the CCHS planned?
Yes, of course, Statistics Canada can speak to this better than I can. My understanding is the CCHS is an ongoing survey. The mental health component of the focus, which was of the 2012 data, has only been done twice. So it was done in 2002, and then again 10 years later in 2012 in 2 separate cross-sectional surveys. My understanding is that in the next cycle, the child maltreatment variables will not be included. But of course, people at Statistics Canada and the research data centers will have more information than I will be able to for that.
Yeah, we will keep you posted. All right, here's another question from Davinder Sin. Thank you, Tracy. Excellent presentation. Are you aware of what research has been done reporting on effective interventions on a population level to reduce child maltreatment?
Yeah, that's an excellent question. We really, yes, I am very interested in intervention and what we can do. I'm very interested in evidence and making sure that the interventions that are implemented at a population level are effective and doing what we think that they're doing. So the reality is there's still a lot of work that needs to be done in terms of interventions at the population level to reduce the occurrence of child abuse and the reoccurrence of child abuse, and also the negative outcomes that are associated with that experience. So unfortunately, I feel like that there's a lot of unanswered questions and a lot of information we don't know. And I think what is important when we think about intervention at the population level is figuring out what works and also what works for who and what works when. Because I don't think that this is the kind of situation where there's a one-size-fits-all. So that's the kind of detail we need to learn about and understand at the intervention level to implement effective prevention and intervention strategies.
Thank you. And I guess to conclude this webinar, we have one last comment, FYI, from Marta Bruziska. For your information, similar questions to the child maltreatment question on the CCHS were included in a 2014 general survey at StatCan. Some results have already been published, and a full-length report is forthcoming.
Yes. So since the 2012 data, there have been questions on child maltreatment included in several of the StatsCan data sets. So the one you've mentioned, there's also several others that have included measures of that. But this 2012 was the first one that we could look at in a representative sample and also look at it in relation to mental health.
Thank you. I guess that will conclude our webinar for today. Thank you again, Tracy, for this very interesting presentation. And thank you everyone for joining us today. I'd like to take this opportunity to thank our main partners, which are, of course, Statistics Canada, Social Science and Humanities Research Council of Canada, Canadian Foundation for Innovation, Canadian Institute for Health Research, and of course, the university hosting an RDC. The PowerPoint slides and the recording of the video will be available, I believe, probably next week on our KT Corner on our website. So if you'd like to download the PowerPoint or see the video again or share it with your colleague, you're most welcome to do that. And finally, I'd just like to mention that Tracy will do a second webinar with us on November 7, recovering from child abuse. What factors make for better mental health outcome in adulthood? So I hope you will join us, and it's still time to register. Again, Tracy, thanks a lot.
Thank you.